Good morning, good afternoon and good evening, and welcome to this global webinar on cancer care efficiency, a path from evidence to implementation. My name is Mark Lawler. I'm Professor of Digital Health at Queen's University Belfast, and I'm also a member of the European Cancer Organisation Board. This webinar, which is in a really important area, cancer care efficiency, has been organised by the European Health Forum Gastein in close collaboration with All.Can International and also supported by Bristol-Myers Squibb. Inefficient cancer care can really be a leading factor in poorer outcomes for patients worldwide. We feel that building efficiency in cancer care requires health systems to operate as highly effective, evidence-based, and most importantly, data-driven learning systems. But this cannot be achieved without a coordinated effort to eliminate the existing fragmentation of data, the occurrence of data silos, and the need for metrics. And that's really going to be what we will focus on over the next period of time. I'm really looking forward to this session. I'm just going to introduce the panelists first. You'll first hear from Matt Hickey, who's the CEO from the Health Value Alliance, and he will present a recent study that's been really important and really influential. And I'm sure you're going to be interested in what he has to say. Nicoletta Antone, who's the head of the Breast Cancer Center at the Cancer Institute of Leon Chiricota, is one of our panelists, as is Brian Bennett, who's director of Worldwide HEOR and Patient Reported Outcomes for Oncology at BMS. Eric Briers, who's the Vice Chair of the Europo-OMO, will provide the patient perspective. And then we're also delighted to hear from Niek Klanzinka, who's the Strategic Advisor of the Healthcare Quality Indicator Program at OECD. And finally, but not least, Virpi Sulasari, who's the President-elect of EONS, will give that healthcare professional perspective. So without further ado, I'm going to hand over to Matt, who's going to give his presentation. Matt, the floor is yours.
Super. So it's a pleasure again to be presenting what we've done with in collaboration with All.Can, the Health Value Alliance, and the University of Southampton regarding the cancer efficiency metric study. As the slide in front of you says, it's a collaborative program between three key stakeholders, really to look at how we define and measure cancer efficiency with a standardized set of metrics. And as you'll see on the first slide here is All.Can's definition of efficiency, which I think is is important for us to understand as we progress through this discussion. And All.Can defines efficiency as care that delivers the best possible health outcomes using human, financial, infrastructural, and technological resources available, with a focus on what really matters to patients and society. Next slide, please. So the report really built on previous work that All.Can has been doing over the last few years, starting really with the Cancer Patient Survey, which was a survey of around 4,000 patients across 10 countries, looking at what cancer efficiency meant to patients. We built upon that piece of work with the cancer data paper, which came out last year, and then finally this metrics, efficiency metrics. And the report, this latest report, the efficiency metric study, is to identify the evidence base behind the core set of cancer metrics that related to efficiency, but also with regard to the stakeholder perspectives across the cancer care ecosystem and how they perceived cancer efficiency, and correlating the research, the databases, etc., that we use, the real world data that are available, with the perceptions of those across the ecosystem, with the intention of having a standardized set of metrics that can be applied, whether it's in various ways, depending on your organization, by the different stakeholders across the cancer care continuum and in different countries. And I think one of the important things here is that when we're talking to different stakeholders, we use terminology, but the perception of outcomes, quality, value, good, efficiency may differ depending on the stakeholder that you're talking to, and therefore so too do the metrics in many cases. So by bringing together a core set of metrics, we're able to get some commonality between the different stakeholders, which is important. So very quickly, moving into the methodology that was used by the university, we looked not just at the online databases with Cochrane reviews, etc., to determine what the evidence was telling us around what cancer efficiency meant, but also into the real world data that's collected routinely in electronic medical records and registries across the world to see whether the literature and the evidence married up with what was being collected. And then lastly, but not least, we then went into some interviews with stakeholders from across the industry, again, as I mentioned, to get the perception of those stakeholders as to what they meant and the key terminologies and metrics that they thought were important. What that resulted in were over 2,000 publications being identified in 15 registries, the interviews, and we boiled all of that information down to a set of categories. So 13 metric categories, which we'll get onto shortly, 24 metric themes, and ultimately 137 efficiency metrics. Next slide, please. So what you'll see here is the first set of us boiling down this information that we did with the study. There's 13 key categories here, many of which I'm sure the viewers will recognize. But what we saw across all three of the sources, the interviews, the registries, and the publications were timeliness of care, quality of care, and financial toxicity. And financial toxicity is an important one because we're not just talking about the effect of patient out-of-pocket expenses. And some of you may be familiar with the Macmillan reports looking at between 640 or 540 to 570 pounds per month out-of-pocket expenses to patients once diagnosed with cancer, but also the toxicity that exists within the ecosystem, be that overutilization of services, inefficient utilization of services, and even fraud, waste, and abuse. So that was a theme that came across all of the different areas of review. Next slide, please. Delving a little bit deeper down into the 24 metric themes, I won't read this out for the benefit of time, but you can see under each of the different categories, we're now boiling down into key areas of those categories. So timeliness of care, for example, swift diagnosis, quality of care, physician adherence to national guidelines. Continuity of care could be looking at patient experiences of continuity of care. And again, I emphasize the fact this is very patient-centric. If we look over to the right-hand side, we're in information support and decision-making, patient voice and patient-centered inpatient care with regard to their involvement and the satisfaction in the way the care is delivered to them. And you'll see survivorship and financial toxicity metrics or categories coming under this. Next slide, please. So once we looked across all of the different areas and we boiled down the categories to the metric themes down into a correlation between the stakeholders, interviews, etc., we came up with 8 core metrics that were common across all of those areas. And you'll see them on the screen here. Time to diagnosis, percentage of cancers diagnosed through emergency presentation, which we know results in poorer outcomes. Primary care interval is an interesting one. That's the time from primary care from the point of seeing your GP to the point that the GP refers on to further investigation and how long that takes from the presentation of symptoms. So what's interesting on this particular slide is that we've been able to boil down across all of the different areas 8 core metrics, even though we still have 137 metrics that we could utilize. Next slide, please. So from the basis of this report, which really was a foundational piece of research, we really came out with a call to action to the industry. Having done the work that we've done now, we want the industry to utilize this report to further validate the metrics within their own setting, whatever that may be, whether that's a hospital or a commissioner of care or a policy or whatever the case may be. And utilize these metrics as a method of baselining. So starting with something that is common and doing baselining and progressive analysis to understand how your particular initiative is improving efficiency in multiple settings, and of course sharing that out to the ecosystem. And then, of course, what we're looking to do further with other pieces of work by All.Can and other collaborators, and also calling to the industry to do the same, is to expand the research that we've done here. So be that going into looking at the correlation of quality of life with innovation assessment, digital use of digital prompts, and wider socioeconomic analysis, so that we can understand better the power of innovation and the return of investment through improvement in quality of life, survivorship, and long-term financial sustainability. And I thought it pertinent also to end this slide on one of the quotes from the report from one of our patients, which is, efficiency would save lives like mine, which is by far the most important thing to patients. And I think we should bear that in mind. I would also add that as we've done the call to the industry to move this into real world application, there is a real world application being applied now through the Health Value Alliance with a global collaboration program called the Cancer Performance Indicator that we're pulling together at the moment with stakeholders from across the industry, who will be taking this as a baseline to determine key metrics that we want to quality assess cancer services with and cancer innovations going forward, to understand the core outcomes, the root causes of value improvement, and how to commission more smartly, shall we say, through outcomes with a standardized model. So the exciting part of this is the report has been done, and we're already moving this into a real world application, and we would call other stakeholders to do the same. Thank you very much, Mark. I think that wraps me up.
Thanks very much, Matt. Really interesting work, really important as well, as I highlighted at the very start. And I love your patient quote. And it's really, your focus on the patient viewpoint is incredibly important in relation to this area of cancer care efficiency. We're now going to go into a audience poll, Matt, where we are going to, obviously, the panel are going to respond to your presentation, and we're going to discuss that in sort of lightning presentations. But just before that, I want to go into a poll, and this is the first question we're going to ask the audience in relation to, and what I've just have it should have come up there in front of you. And the question is, in your opinion, what are the top 3 areas, so this is a multiple choice, where metrics should be applied to improve cancer care efficiency? So you can see there are 5 options: timeliness of care, quality of care, patient experience and involvement in care, financial toxicity, and palliative end of life care. So if you wouldn't mind voting on that, and just to say, the hosts and the panelists, I'm not allowed to vote, and neither are the panelists, but we want the audience to vote. So if you could vote now. Okay, hopefully that's been enough time for everybody to vote. If we can start to look at the results that are coming through from that, that would be great. Okay, so here are the results. You can see there, timeliness of care, again, a really important area, but quality. And I think that reflects what Mal had said in relation to quality and also the patient experience. But we can see that all of them have scored reasonably strongly, maybe palliative care slightly less than you might expect, but probably a more specialist area. But really interesting information from that, and capturing, I think, some of the points that Matt made during his presentation as well. So thank you, audience, and obviously this is a way of me encouraging you to ask questions. So if you want to ask questions, put them in the Q&A. I'll endeavour to answer, get the panelists to answer all the questions. We're now going to go into a rapid fire session, where we really want to see some lightning reflections from each of the panelists. I'm going to go to Niek first, and really, what do you think is needed at the policy level to implement the metrics that have been presented, despite the differences that we see between different countries and different settings?
Thank you, Mark, and it's a pleasure to participate in the webinar today on behalf of the OECD, the Organization for Economic Cooperation and Development. And the metrics that are presented in the study and are also voted by the participants today are very much in line with, apologies. They seem very much in line with what the OECD is also looking at the moment. So just to remind you, a report was already issued in 2013 that looks at quality of care, but has the same pathway approach in looking at the functioning of the care delivery systems in OECD member states. And I would just like to mention 4 streams of work that are at this moment existing with the governments of the OECD countries that do embed already part of these measures. So the first, and many of you are aware of this, is the work on the Beating Cancer Plan of the European Union. So the OECD has been commissioned by the European Union to work as part of the Inequalities Registry on a series of 29 country profiles. And these country profiles on cancer care describe the situation with cancer care in the 27 EU member states and Norway and Iceland. Part of these profiles is a description of the access, the quality, and the cost of cancer care. And that's very much in line with what the 8 categories are in the report. The draft reports are now there. Me and my colleagues have been involved in the past 6 months in in-depth interviews with all of the member states and experts. There are now 29 draft country profiles, which are reviewed by the member states, and all the reports will be released by the EU on the World Cancer Day next year. But just to assure you, that is already, from an international perspective, a way of looking at things.
Thank you very much, Nick. That's really useful.
Yeah, and then the second part of work, and I'll be short on that, is the whole Paris program. I had the pleasure in the previous EHFG seminar to present that, but that looks at patient-reported outcomes and involvement. So there's a whole PREMS and PROMS program, including a project on breast cancer that involve it. There is another international program on the end-of-life care and getting intelligence there to make it comparable, and a lot of work of strengthening the data infrastructure of the member states. All these things happy to share further in the debate, but ways where there is synergy between this report and what is happening. Just 2 focal points. Our present attention of the OECD is, after the COVID, very much on access, because we saw the impact of the postponement of a lot of services, not just the screening, but also the access to cancer services. You will read that in the next version of Health at a Glance, released in November in a separate chapter. And we are also now looking very much at the inequalities with respect to the income, because given the present economic crisis and the inflation, the OECD is really concerned in assessing that the access and quality of care keep guaranteed also under economic challenging circumstances. I'll stop there, but happy to have the discussion. But overall message, great work, metrics in line with what is there, but also routes where this work would strengthen and could have synergy with already existing activities that are done by governments.
Okay, thank you very much, Nick. Going to move from the macro level of OECD now to the more meso level and at the practical country level. And really, Nicoletta will be very interested in your perspective from a Romanian Breast Cancer Center perspective in terms of the added value from your point of view.
Yes, thank you. Thank you very much for the question. So I will try to explain a little bit, because also the process it's important. So we are right now in the process of international certification of our breast cancer center, and we started last year, and I have a little bit of the experience on what was before and what it is now. So what I feel the most important barriers that are at this moment in our institution is, and I will start with the first one that I keep repeating, that's very important. It regards access to data. And when I mean data, I mean local data, institutional data, but also the lack of national cancer registries. So this is one of the big issues, because also in this process of certification, they are asking us to perform and to give the statistics, and the fact that we don't have the National Cancer Registry is one of the barriers, or institutional registries. So this is one of the things. The other one I feel on the local level, as I said before, is that we don't have a very standardized clinical pathway for our patients. So the patient does not know what exactly are the steps from access to diagnosis and treatment. So this is another issue that we can discuss about that, because this is very important. We all know the timelines that the metrics have shown us are very important. So we need to increase our best practices by increasing and having standard operating procedures. And I believe that step by step, if we start certifying one cancer center and then to another cancer center from one single institution, and then from one institution to another, to create a network of institutions that actually use the same pathways and the same standardizing procedures, will increase access to data, diagnose, treatment, clinical trials, and so on. So this is my feeling, my personal opinion, because as I said, we don't have the data to present right now, but maybe we should try to also collect this, what was before and after certification of a breast cancer.
Thank you very much, Nicoletta. And really important point that I absolutely agree with. The importance of data and turning data into intelligence to actually help in relation to how we manage cancer control within individual countries as well as right across Europe. Eric, from the patient perspective, what do you think the cancer care efficiency metrics mean, and what is their relevance?
Well, it is highly relevant because we are a big group of patients in Europe. And our patients with cancer, they need for very long periods of time a lot of care. And this care is very expensive and has a big impact on the healthcare budget in the country. So metrics are very important, and using them very efficiently for the patient's best is of the highest importance. Because of course, we want the best of care to give us the best quality of life. And if we look at that, we see that at this moment with the Europe Beating Cancer Plan and the very recent advice from the Commission on extending the screening to prostate cancer is a very important step to contain the cost. If we just look at what a timely diagnosed prostate cancer treatment would cost if he's high risk, you should say about 25 to 50,000 euros. If we detect this too late and we have a metastatic cancer and we take then the end-of-life treatment, we are looking at something between 300,000 and 1 million euros for one patient, depending on how long he's needing this care. So it's extremely important that as well, looking at what we can measure now as cost and quality, we have to look how we can improve this. And we have possibilities to improve this by establishing, together with all the other stakeholders, an efficient system of screening for not only prostate cancer, also lung cancer, which is the major killer. Thank you.
Thank you very much, Eric, and really giving both the patient perspective, but also the cost and the financial costs and toxicity, which I think is an important and sometimes under researched area in this regard. And Virpi, I really interested to hear both the perspective of the healthcare provider, but also the healthcare workers in relation to cancer efficiency metrics.
Thank you, Mark. This is an excellent question, actually. We often talk about the challenges, but it is really important that we also see the benefits if we develop the systems and we integrate cancer care efficiency metrics as part of the organization data pools. So first I need to say a few words about from practice about leadership, because like Mark, you said earlier on, so healthcare organizations are very much data-driven systems, and they can even be called like knowledge-intensive organizations, since the knowledge is one of the vital assets of that organization. And the information we can produce through cancer efficiency metrics are needed really for the leadership do knowledge-based management and informed decisions. And these do include organization, benefits for organization of the care delivery, optimal allocation of resources. For example, I'm talking about financial and human resource planning, evaluation data on how the healthcare providers, the organization are reaching their goals and the care outcomes, but also on success of introducing different integrative collaborative models in multidisciplinary care, digital care pathways, and moreover to improve the quality of care. So we can use this data to identify those existing gaps and also non-efficient operations, meaning that we can really learn and commit to continuous improvement. And I can see that in the future, we will be using more and more also artificial intelligence tools and different type of algorithms, which will support the knowledge-based management. But for the individual healthcare worker or the unit, smaller units, so I think the benefits are related to better understanding of the current ways we are doing now. Are we doing it efficiently? It helps us to identify the needs for change and how we can deliver the care, develop the care to more person-centered. But also, I would say one of the benefits is that it really makes visible the work of healthcare workers, so that we have the facts for human resource planning and developing the cancer care. And this in turn can have the impact on job satisfaction, commitment, well-being at work, and also better opportunities for education and career development. And those patient-reported outcome measures are important also as they give feedback for the people who are working in practice in the cancer care unit. So they can see what they are. It's kind of a positive power, empowerment for them also to go further, even in very often difficult circumstances. So they can ask themselves, are they doing their best? Can they do their best? And what they could do, or the unit, like we can do better. Thank you, Mark. So I hope
some really important points there. Thank you there, and particularly the relevance in relation to healthcare workers. So thank you very much for that. Brian, I'm interested to hear what you feel from the private sector can add in this regard.
Yep, definitely. Thank you, Mark, and thank you for the opportunity of being part of the panel. So I would just like to echo what everyone in the panel has said so far. Thinking about our reflections of these efficiency metrics. And so we at Bristol-Myers Squibb believe that everyone should have a fair and just opportunity to be diagnosed in a timely manner, to be treated with the most effective treatments, and that opportunity to survive cancer regardless of where they live. So that should be an opportunity for everyone. We also believe that driving more efficiency across that entire care continuum by investing and focusing resources where they matter the most is central to improving health equity in cancer care. Therefore, these efficiency metrics, they truly represent an important building block towards more efficient cancer care, and crucially focusing on what matters most to the patient. So we believe, that this, in a time of patient centricity, these efficiency metrics are a really good starting point. In terms of, the private sector, we believe that the private sector has that exact same accountability as the public sector in implementation of these cancer care metrics, and therefore private and public sector goals need to be aligned to deliver better outcomes for patients. Anything that we can do to improve the outcomes for patients, regardless of where they live or where they are, is definitely a good thing. So the development of these efficiency metrics is a positive step forward.
Thanks very much, Brian. I liked your focus on equity and on making sure that it doesn't matter where you live, you should still get the same treatment in relation to cancer diagnosis, cancer therapy, etc. Matt, would you like maybe just to reflect just maybe some on the comments of the panelists, but also on the real world application of these metrics? Because obviously metrics are all well and fine, but it's important how do we actually implement them?
Yeah, thank you, Mark. And actually, I'll hark back to what you just said, Brian. because just not long ago, back in April this year, I stepped out as being the head of cancer for a major insurer. Fundamentally, to do what you just suggested, Mark, is to get a real-world application of these metrics in one way or form by bringing together a collaboration of the different stakeholders across the industry. And that includes, as Mark was representing, pharmaceutical companies, insurers, patient advocacy groups, and academia and hospitals and clinicians. Fundamentally, again, looking back at what is it that we need to be providing as an ecosystem to our patient in the most efficient, effective manner, who is the customer of all of us, and ensuring that we do so in a financially sustainable manner. So there's equity, not just within what the patient can access, but also equity within the way that we manage the ecosystem responsibly and financially, so that it is indeed sustainable. And that goes back to what you were saying, Virpi, as well, that the system runs on an organizational infrastructure, and that infrastructure needs to be effective and efficient and financially viable, and that includes the workers. So we have to have a diverse and happy and focused workforce, focusing on the individual within an ecosystem that is sustainable. That infrastructure builds around and encapsulates the patient to deliver their needs within the most effective manner. So this real-world application, this development of the new cancer performance indicator, is understanding what performance means by those different stakeholders, utilizing this metrics, base of metrics, and determining and agreeing across the stakeholders how to take that forward into a real-world application.
Thanks very much, Matt. I'm very clear, and I think obviously as well, we've talked about this before. Delighted that you've taken this pathway as well, because I think it's really important. And again, it's critically important that all stakeholders are part of that process, and that's been very much a feature of this initiative as you've moved it forward. We're now going to go into another audience poll. This one's a slightly more difficult one because we're only giving you one choice. And if we again can just have the poll questions up on the screen. So this is our second question, and we're essentially asking you to one of three options. So the first one is hospitals and oncology facilities to have financing conditioned by a minimum provision of data, including some covering the metrics. So that's your first option. Then the second option, hospitals, and in brackets oncological wards as well, oncology facilities to have accreditation conditions by implementation of a set of essential metrics. And then number three, other. And then if you do go for other, if you wouldn't mind putting your thoughts in the chat as well. So again, we'll open this up for your voting by the audience. We'll give you a little bit more time just in case some of you are doing three and you have to put something in the chat as well. So if you can start to vote now. Okay, if we can then see the votes for this question, that would be great. So interestingly, most going for option two, in terms of having sort of more effective ways. It's, in terms of the ways in which we actually look at facilities and accreditation conditions, and then also a significant number going for the more financially focused area. And so again, I think that's interesting, and we'd be interested to see what the other there is in terms of what were the specific questions in relation to that. So thank you very much for that. Just very quickly, I'd like to hear the opinions of the audience in terms of, I know I told you not to vote, but if you were voting, what would you have voted for? Eric.
Thank you. It would have been a problem for me because 1 and 2 should be together. So first of all, we need our expert centers for the treatment of cancers, any cancers, to follow specific accreditation conditions, which would be also following some of the essential metrics, but they should report that so that we create data, and that these data, which is number one, will allow supervisors somewhere to continuously judge if these expert centers are still in line with the optimal care for patients. So it should be 2 and 1 combined.
Okay, thank you very much indeed. Virpi.
Thank you. I actually am going to answer pretty much the same. So I would combine the two. So I think it's good to have an outside force, which like accreditation requirements that forces us to develop the system. However, we need the financial support to be actually developing, for instance, how we integrate the metrics into electronic patient record systems. Thank you.
Thanks very much indeed. Nicoletta?
Yes, so I also agree with my colleagues, and I consider then one option doesn't exclude the other one. So in the process of accreditation, you need to present data, as we are all discussing about this. So I think both of the options are valid and also very important. So provision of data remains, and I will keep saying this. Hopefully, at some point, who needs to hear will hear. It's really important. Thank you.
Thank you very much indeed. Brian?
Yeah, so no surprises. I agree with the panelists, the other panelists. I think it's important to have both combined. I think also what's important is there's some element of accountability with that accreditation so that we can monitor in the longer term as well and provide additional training where it's necessary and support.
Thanks very much indeed. And finally, Niek.
Thank you. I would probably vote other, but with that I mean that I would vote for accreditation models in cancer care that look at integrated delivery systems. So that take the network and the pathway as a full point, and hence use accreditation not to freeze the existing hospital and ward dependent on oncology, but really go on the bandwagon of integrated delivery systems and accountable care organizations that are now forming in many of the countries. And doing that, I would be happy to think over financial incentives, but again, I would link them to the overall community and integrated delivery system that provides cancer care rather than to individual components.
Okay, thank you very much indeed. So I think, you know, a broad agreement among the panelists in relation to bringing together different aspects is really important. Just Matt, from your point of view, obviously you're maybe poacher turned gatekeeper. Just your thoughts in relation to that.
Yeah, I broadly, thanks, Mark. I broadly agree with the others. I'll just take a stepwise approach. I would advocate going for accreditation first.
Okay.
But ensuring that accreditation has, as Nick was just stating, that has the accreditation has the appropriate metrics within it that enable us to identify the financial and infrastructural inefficiencies as well. Therefore, we can pick up the financial side of it by going through accreditation, and then you're in a position to be able to monitor progressively thereafter.
Okay, no, absolutely. We're now going to go into a sort of a more open panel discussion where I'm going to set a series of questions. I'm not necessarily going to ask everybody to answer every question just in the interest of time, but I think one of the things, you know, it's certainly been very clear to me that everybody is very positive about these evidence-based metrics. I suppose what I want to ask is, what are the hindrances? So what are the blockages that would actually make it more difficult to implement them? And maybe start with Niek, if that's okay.
No, happy to. And of course, I'm looking from an international perspective, and the attempts that have been done by the OECD are still ongoing to get international comparative metrics. But a big one is, as you understand, the data. Are the data in your systems that can construct the metrics? And especially with the ones that have to do with timeliness, you quite often have to link the database from primary care or the hospital and others. And so it mainly often boils down to lack of linkage capability, impossibility of grouping data because of privacy regulations. So that I see as a main hindrance. And that's why I mentioned the 4th track of work we had at the OECD, which really helping countries to strengthen their data infrastructure to really support integrated delivery models. The other thing that can be a hindrance is the vested interests of the different stakeholders and the parties. So, and I see that especially if you come to the concentration of cancer services, of a redistribution, of course, that creates a lot of tension. So I speak with the policymakers and the ministers that try to rationalize evidence-based the availability of centers. But in reality, if you try to concentrate certain cancer services because evidence-based, you know that will provide better outcomes, you are into a very complex political process. So I'll stop there. The data infrastructure and the political process needed to implement at least some major redesign changes.
Thanks very much, Nick. Eric, from the patient perspective, what are the blockages or the things that may hinder this being a reality?
Yeah, well, evidence-based metrics, they are, in my view, also linked to the evidence-based treatments that we can deliver to patients. And one of the hindrances we have in, if you look at Europe, is that we can have excellent guidelines and ask for the use of some technological tools to deliver the care, to diagnose the disease, but we have to see that these tools are not necessarily available across Europe. That in some of our member states, the availability of PET-CT scanners, for instance, is much lower than in other countries, which may limit the access to optimal care for patients. So metrics that we can use in the Western countries, like the Nordic and Belgium, the Netherlands, France, etc., may be very difficult to achieve in other countries. If we look at the Eastern countries in Europe, this does not change the evidence on which the guidelines are built, because they are independent of availability, but they make the rollout of the top treatment of the shortest course to a treatment, the quality of care makes it different if you look across Europe.
Thank you very much. Really important point in relation to inequalities and narrowing inequalities. Just final in relation to this particular question, Nicoletta, I'd like to hear your opinion.
Thank you. Thank you. I was just thinking about the clinician perspective regarding this. So as I said, I would not say and not repeat what my colleagues have said before, but I believe that it's very, very important for us, the clinicians, to have the institutional guidelines, the institutional procedures, to have the standard operating procedures. Like, for example, even for, I don't know, a second opinion case that presents to our institution, we should have a very good operating standard procedures, so everybody knows what happens with the patient. So this is one thought that I was thinking about. The other one is maybe we should think also about the resource stratified guidelines, because we know there are a lot of international associations that are providing this resource stratified guidelines, and we should educate ourselves and see exactly what is our level and what we can provide for the patient. And maybe this will also decrease the financial toxicity for our reimbursement, house of reimbursement, and the governments and the patient and so on. So educating ourselves, trying to do the standardized procedures, and also to use the guidelines, to use the resource stratified guidelines, and obviously working all together. So this is my point.
Thanks very much, Nicola. I'm going to go into some of the questions that are in the Q&A, some nice questions coming into the Q&A, and I'd encourage the audience to put in more questions as well. This first one is really related to the environment, and it's suggesting that, yes, we can do the different options that were required in relation to the evidence base, etc., but we're then putting the patient back into that same environment. And how do we then ensure that we actually don't just go to a situation where the patient will then subsequently recur or won't have access to certain opportunities, certain treatments, certain supports? So we'll be interested in that. And the follow-on question that's from the same person is, something like oral cancer, for example, you need dentistry to be involved. So sometimes you need areas of medicine that are not maybe cancer specific, but are very relevant to either the diagnosis or the management of certain cancers. Matt, maybe if you wouldn't mind taking that question to start with.
Yeah, sure. So I think the environment is crucial, and I think getting an understanding of what the environment is that patients are circulating within. I mean, we've heard terminology like integrated cancer care used across the discussion here today. Fundamentally, ensuring equitable access to early, speedy, accurate diagnosis beyond screening, that is crucial to what we need to establish first and foremost in this environment. And secondly, ensuring that patients don't go through processes of cyclic healthcare. So they're cycling around from one thing to another, bouncing from pillar and post across disciplines, etc. That's wholly inefficient. If you look at some of the World Health Organization and even data from the OECD, something along 40% of our healthcare services are wasted. And cyclic healthcare service use is to do with that. So we need to fully understand, and to Nicoletta's point as well, exactly what sort of environment we're putting in place for the individual to ensure removal of bottlenecks and efficiency and streamlined access to timely, relevant and personalised care. Otherwise, we're back into this position where patients are not necessarily getting their needs met and they're going around in cyclic healthcare service use.
Thanks, Matt. And Virpi, from your perspective?
Yes, thank you. So I may take here a very also a practical approach, I would say. So thinking about the everyday life of the healthcare professionals, different healthcare professionals working in the cancer care setting. So I think in regards of how we use the guidelines, the evidence-based recommendations, how we embed the cancer efficiency metrics into the system. So those should be also seen from the perspective of the clinicians, like Nicoletta, you said. So how I'm going to do it in my everyday practice, how it's going to be feasible, also in times of, in regards of time and so on. And I often feel that unfortunately, we talk a lot about multidisciplinary care or multidisciplinary care teams or interprofessional collaboration, but sometimes it's just a beautiful word. But then when we introduce different new systems, for example, to monitor some of the outcomes of the organization, so we really should get the professionals together so that they can really talk with one another and how, for instance, we are going to implement this evidence-based recommendation in our particular unit, for instance. So I think we need a very much somewhat practical approaches as well, not just somebody saying that we need to do this, but also that we can ourselves talk together how we are going to do it. So I think we might be more successful in that way.
Okay, thank you very much, Virpi. Going to go to another question now, and a really important area, good question, this HTA and HTA recommendations. One of the challenges, obviously, that we're facing in Europe is, how do we make sure that they're mandatory, they're implemented, and not at the discretion of each country? I know that's a big question, but it would be one that I'd be interested in hearing the panel answering, and I'll maybe start with Brian.
Yeah, so before I answer that, and I guess related to that is within the cancer care ecosystem, the way I see it is there's lots of little siloed groups working away, and there's a lack of synergies across many different stakeholders. So I think in order for recommendations to be mandatory and implemented, we need greater efficiencies and synergies across each of the different stakeholders. I think that's absolutely crucial. I think the other thing that we have to realize is, this is a long-term strategy. It's not going to happen overnight. So there needs to be long-term commitments from each of the stakeholders and continuous open dialogue, and also a paradigm shift to focus on value from the patient's perspective.
Really delighted that you focus on that value perspective. I think that's really critically important. Just in terms of, Eric, from the patient perspective in relation to HTA, just your thoughts on that, I'd really be interested in hearing them.
Yeah, well, for us, it's of course a pity that there's no European health technology assessment, because as a consequence of that, we have in the different countries, after a new therapy, a medicine, is approved by EMA. It can take so different times in the different member states before they are available to patients. It can go from very short weeks in Germany to years in other countries, because they all do their own health technology assessment for medicines. And based on that, they will go and decide whether or not they want to reimburse it. It is a very strange thing that the conclusion of this can be so different from country to country. We're talking about the same disease, we're talking about similar patients, and still in some countries it is not reimbursed, and in others it is very fast. So for me, I would welcome a European common health technology assessment, which would then be the basis of discussion on reimbursement in different countries, and not the kind of secret negotiations we have today.
Yeah, no, absolutely. We were doing a session yesterday in the Cancer Drug Discovery Forum, or Drug Development Forum, in relation to exactly this area, and a lot of discussions similar to what you're saying, Eric. And Matt, maybe finally, just from you, just be interested in your perspective.
Yeah, so I think I actually echo a lot of what Eric's just said. Is the ability to centralise them, and part of what we're doing with these metrics report is actually getting the collaborators together from different countries to try to get that synergy and to get that common view. The other thing that I would also advocate, and you used the term before, Brian, value, is determining what value actually means. A, to the patient, of course, but also when we're looking at health economics and the long-term assessment of an HTA, is to have a standardized methodology of doing that, and then tracking and monitoring that value over time. Because one of the dimensions we often don't look at when we're looking at value-based healthcare or value-based models or HTA is the time to good return of investment for an HTA. And it might be that a drug is cheaper, shall we say, at the front end, but could result in late effects, which could actually erode the value in time. So I would advocate a centralized methodology, but also that time is included in that, so that we really understand that value is derived over a period. Particularly important when you're looking at the way that the commissioners look at purchasing any innovation, whether that's drugs or radiotherapy, whatever the case may be.
Thanks very much indeed, Matt. Going to go on to another question now, and it's about collaboration and partnership, but also leadership, which we mentioned earlier. Really interested in what your thoughts are in terms of how and what kind of collaboration and partnership you think will work best, particularly within a cancer care ecosystem, but also the role of leadership and how that actually will drive this initiative forward. We'd start with Nicoletta.
Yes, thank you. So it is very, very important to understand that we all need to work together, and that includes all the stakeholders, the clinicians, the patients, the private practice, the public practice, and we always have to put in the center the patient. So this is one of the things. And the other things regarding leadership, yes, this is also very important, because in countries like Romania, we don't have how should I say, courses where we can learn about leadership. It's very important. And I remember we met in Poland in June at the European School of Oncology leadership course. That was the first one in this initiative. And I'm very honored and happy that I had the opportunity to participate. Well, I felt I learned so many things, and it helped me so much to grow and to educate myself. But this was done with international societies and with international help. As I said before, we don't actually have it in our hands here, this option. So leadership is important. We should create leaders. We know that not everyone can be a leader, but we should select clinicians and patient advocates and so on that can learn, because this is also learning. It's something, it's innate, but you can also learn about leadership. So educating ourselves continuously in this area, also not only the medical practice. Also learning to become a leader, to speak out loud and try to explain all the barriers that we are facing on, because in the end, many of us face the same problems. So
absolutely, and it's great to see you again after Warsaw. And I thought it was a really good meeting that we had there, and I agree with you. It's something, and obviously we're going to run that meeting again, but it's something that I think is really important right across Europe. That sort of leadership and looking at ways in which we can help to support and mentor leadership is particularly important. And yeah, from your perspective, we'll be interested in your thoughts.
Well, I fully agree with strengthening leadership and cooperation in the field of cancer care. And I think you need leaders for all the different stakeholders. So you need leaders in the patient organizations. You need strong leaders in the professional groups. You need leaders in the managerial sides. You need leaders in the policy making, and not last with your government, having a clear vision and a cancer strategy where they want to go. And I'm just referring to the last round of the in-depth interviews we had with member states. There you see that countries are in different phases when it comes to integrating and cooperating. So the use, the active involvement of patients, not just asking about experiences or prams, but involving them in the design of the system and co-owning it, really differs a lot across the continuum. The really involvement of professionals in having the capability of redesigning their own work. And there again, there's a big problem coming there, because all the countries report the labor market shortages that will play out in the coming 10 years. So the external pressure is really high to stress cooperation. And as I mentioned earlier, I think a good data infrastructure that supports decision-making and more integrated delivery models are the way forward. But yes, you need the leadership and also the willingness of the leaders of the various stakeholders to see this system perspective and move that forward. And that was my remark earlier. In some countries, I think many leaders are also in their own bubble of rationale, but that doesn't necessarily contribute to the optimization of the system as a whole. So important. And with respect, Nicoletta, to Romania, I know Romania is now becoming a member of the OECD, so there's a lot of work going on. And just to mention one thing, I had the pleasure of teaching the leadership of your universities in all the medical faculties on the basics of health economics. So it also starts with people knowing what health technology assessment is, but also the basics of economics, how it functions, so that people at least have those competences if from an academic role they start interacting with how to shape the healthcare system and cancer care. I know about your problem with the registries. It would be great if there would be coverage of registries on the whole of Romania. It would even be better that the registry you have would also have staging information, so that we can, like in other countries, really see what the impact of COVID is on the moments that people are diagnosed with cancer. But yes, you have, this is me saying leadership and cooperation, yes, but you have to contextualize to the country where you're working on, like where the situation is completely different in Romania as it is in Finland.
Okay, thank you very much, Niek. Really important points there, and linking nicely into our previous comments in relation to this question. I'm going to take another question from the chat. Going back to HTA, obviously a popular area, and specifically the questions, I'm just going to go to the nub of what the question is. It's really looking at, how do we measure access to oncology products in the EU member states, and how does a sort of an EU HTA, which will come in hopefully in 2025 in relation to both oncology products and ATMPs, how will that contribute to improved access to those products in different EU member states? Maybe start with Brian on this.
Sorry, a very crucial point there, access across the entire community. As I said before, I think we need greater synergies. We need to put the patient at the center of what we're doing. Many different HTA agencies have their own individual evaluations, and when you have no one has an infinite pot of resources. So they have to, HTAs have to evaluate the value of a drug with the resources that they have. But if there was greater collaboration amongst each of the different HTA agencies and some standardization, that may lead to better access to transformational medicines within cancer.
No, thank you very much. Really good points there. Matt?
Yeah, I don't have a huge amount to add over what Brian's actually said. Other than the fact that we need to understand this method of standardization. And Nick, in the case you've said is the contextualization. So it's not, there should be a commonality in the basic assessments here, but then we should be able to contextualize. I would also echo what you've said, Brian, is that we do, as an ecosystem, have finite resources. So it's really important that any HTA that comes to the market understands, when I was talking before about value, how, and to your point, Nick, about the health economics, how health economics of the HTA and the assessment of that and the affordability, it needs to be assessed and maintained and monitored over time to ensure that we've got fair and equitable access. We would like us to be able to get access to everything, but that's not the reality. So there's a obligation on the HTAs and us as an ecosystem to enable the HTAs to present value to the mechanism that has to pay for this at the end of the day.
Thanks, Matt. And Eric.
Thank you. It still is. It's a critical point, and if I understand it well, there will be some sort of European collaboration on oncological medicines and on ATMPs. But it will be rather free, because it would be an advice to the member states that they can use or they cannot use. So there is in the end not so much difference from the present system, because if you want to have a common European health technology assessment, it should not give too much liberty. There can be some freedom, because the cultural differences in countries may differ, and they may have an influence on the final outcome of health technology assessment and also on what is considered an appropriate reimbursement proposal, because this is a negotiation with a company. So it's definitely a good step to have a common analysis, but not too much freedom. We know the system at the European level of directives and other legal means. If it's a directive, every country has its own way of dealing with it, and we get a very diversified application, a regulation that is fixed and fertig. It's what it is, and we'll all have to live with it.
Okay, thank you very much, Eric. I can't believe how quickly this session has gone. It obviously means that we're having a good time. I'm not pushing you too hard in relation to the questions, but challenging you enough. So what I'd like to do now is maybe for each of you to give me just some of your final thoughts in relation to what you feel are the important points, but also the key sort of take-home messages for the audience. I'll start with Virpi.
Thank you, Mark. So just to sum up, so I would like to highlight that to improve the efficiency in cancer care and to embed the cancer efficiency metrics in the healthcare organizations and the everyday work of clinicians. So I do think that we need a very strong leadership in this area and also multidisciplinary leadership. We should not work in silos. So we need to work really together and involve also the healthcare professionals and the patient advocates. And that's how we can tackle some of the workforce challenges, but moreover to improve the quality of care and access to quality care.
Thank you very much indeed. Niek?
Yeah, just like to echo that. I think implementing these efficiency measures is essential, and you only have to look at the economic situation and the pressures to see that increasing the efficiency is key. I think the routes that I showed you, integrated delivery systems and uniform and a good information infrastructure in a country are key to realizing it. So I would at least do that. The other point, and I think Eric was one of the few we brought that, we're not just talking about increasing the efficiency of the care delivery. From an economic point of view and a system point of view, there are also the long-term balance between investing in prevention and investing in care. So from an OECD perspective, we do both. We try to help to optimize the efficiency in the care delivery system. And yeah, part of that is oncological products and how they are picked up in the various systems. But from an overall macroeconomic perspective, it's as important to redress the balance between what you spend on the care delivery and what you spend on prevention. So that's another aspect. I just wanted to stress here that we're not there by optimizing just the performance of the care delivery, cancer care, but at the same time should try to work on the risk factors and the screening if in the long run you want to reduce the burden of cancer.
Yeah, no, absolutely, very much so. Embedding this within the overall cancer continuum and how we address the cancer continuum. Very good point. Nicoletta.
Yes, so I think that at the beginning, we need to understand what metrics are. So we need to understand and learn and continuously educate ourselves to understand what the metrics are. And afterwards, we need to implement, maybe we cannot succeed with all of them, but one step by step, one by one, in our institutions, and to also to try to collect the data to see how it was before and after implementing the metrics. So data is very important for us, and to educate and try to create leaders, to try to create strong leaders. Leadership is also very important, to be vocal about our barriers and things that are happening in our small micro environment, and afterward to extend it to the macro environment. So these are my thoughts.
Thank you very much, Nicoletta. Really important points as well, and echoing some of the comments that were made earlier. Next, I'm going to go to Eric.
Thank you. Just briefly, it is collaboration, patient involvement, because if we don't collaborate, then we have to go cross-border, because we are talking now as if all cancers are within reach of the experts, but some rare cancers are very far away from the experts. So collaboration cross-border if needed, and collaboration with patients. I do want to add one thing that has not been discussed. For efficiency, we also need, and we discussed that beforehand, we also need to monitor what the benefit of new treatments and of new medicines is, because we test them in an expert population, statistically valid, absolutely, but what we call wild-type patients, they might not benefit from a new medication. So we also have to do this, and this will improve the metrics in the end and the efficiency.
Yeah, you make an important point, and it goes back to the real world evidence, because obviously, a lot of our clinical trial studies, for example, are very much selected populations. So the importance of real world evidence, but also some of the challenge that real world evidence studies also raise. So it's really important to do that. Brian.
Yes, so my key takeaways from this is the efficiency metrics were drawn from a large body of evidence. So there was over 83 academic articles, there was 43 grey literature publications, there was cancer registries, and also crucially those 20 interviews with different stakeholders across the cancer care ecosystem. From that we identified 137 efficiency metrics and 8 core indicators. Central to all of them is the patient. And I think the implementation of these efficiency metrics would lead to greater equity across the cancer ecosystem, which will result in better outcomes for patients. It's just, here's where we are and here's where we need to be. So it's the implementation of that. And now that we've had this this webinar, and hopefully people will read the report. We have started the process of actual implementation within different stakeholders.
Thank you very much, Brian. And Matt.
Yeah, thanks very much, Mark. I'm just going to reflect on a cyclic argument that we had between a payer and an innovator the other day, where the payer was saying this: the root cause of suboptimal outcomes or suboptimal value is unwarranted variation in clinical practice. So moving beyond evidence-based care. The counter to that was the root cause of value erosion was suboptimal reimbursement, which means that I cannot do what I want to do for my patient. And that argument went round and round and round in circles, with the patient fundamentally either not getting the money that they required to get the medicine, and the payer not getting the evidence of the value of that medicine. So we fundamentally agreed that the value needed to be demonstrated. We needed a set of core metrics that enabled us to do that. That we needed to do that in a collaboration, which is why we've set up this performance indicator, utilizing the cancer, the metrics that you'll see in this report as a baseline, and that could be a catalyst to change. And crucially here is the multi-stakeholder approach, to bring each of the different stakeholders to ensure that we actually saw eye to eye on what we're trying to achieve here in a real world application of the efficiency metrics report, which we're very excited about. So exactly to Brian's point, is we can utilize this as a catalyst of change. I would advocate that when we do so, that we bring that back to whatever group we're able to do so and showcase what we're doing, because then we've got a cyclic learning environment as well.
Thank you very much, Matt, and thank you to all the panelists. I think it's been a really informative session. I think we've covered a lot in relation to the different aspects of what is a challenging situation, but I think it's the right way to go. And we really feel that, you know, one of the core messages I suppose we're trying to get across is the importance, but also the complexity of translating findings into practice. Really when it comes to particularly the standardization of the measurement of efficiency in cancer care practice, and that should be right across the care continuum, and that's been highlighted as well in some of the statements rather than questions in the chat. And we really need, as Nick said, we really need to think about this, of how it impacts within an overall cancer continuum, all the way from prevention, early diagnosis, right through to end-of-life care. And so it's really important that we consider in that context. I think the other thing that's really important, hopefully as a take-home message, is that implementation is the new translation. So translational medicine should now become implementation science. And that's something that, I'm very passionate about myself. It's something that we'll be bringing out in the Lancet Oncology Commission on Cancer Research in Europe, which we launched on the 16th of November at the European Cancer Summit within the Inequalities Network. And it's something really that we really need to think about. I've said this a couple of times, Europe is great at breakthrough. We're not so good at follow through. I think this is another good example where we really need to bring it to its logical conclusion in relation to implementing what I think are an excellent set of core aims and messages that have come from the work that's been done by Matt and the team. It just stays with me just to thank everybody again, to the panel, to Verpi, to Nicoletta, to Niek, to Brian, to Eric, particularly to Matt for the excellent work that he's done and presented it, to the European Health Forum Gastein, to Bristol-Myers Squibb, and to all the participants who've come into this webinar. I think we had over 260 registered, and that's great, which shows that this is an important area. And also to thank the questions that we've received that the panel hopefully answered to your satisfaction. And just would encourage you in the chat there's just asking if you would please fill out the evaluation survey, and also to say that this the YouTube channel, the European Health Forum Gastein YouTube channel, will feature this webinar in approximately a day or two. And so again, if you want to look back and look at some of the aspects of it, or to share it with a colleague, and that would be great. So thank you very much, everybody. I think it's been a really exciting, interesting, provocative, and we hope that you've enjoyed it.